Good morning, everyone. 32 years old antenatal mother G2P1L1 during the 17 week of gestation presented with the chief complaints of right-sided ear pain for 4 days, right-sided ear discharge for 3 days, reducing hearing over the right ear for 3 days, high-grade fever for 2 days, vomiting for 2 days, headache with neck pain for 2 days, and family observed abnormal eye movement for 1 day. History of presenting illness, she was doing well till 5 days back, and then she developed right ear pain followed by right ear discharge. On third day of right ear pain, she developed a high grade fever which is intermittent, associated with chills, and associated with intolerable headache and neck stiffness. No history of loss of consciousness, diplopia, involuntary movements, bladder and bowel incontinence, and past is no known comorbidities. She consumes mixed diet and she has normal bowel and bladder habits. On physical examinations, conscious, dull-oriented, dull-looking, febrile, no pallor, icterus, cyanosis, clubbing, pedal edema, generalized lymphadenopathy. Vitals were stable. Central nervous system examinations, her higher mental functions were intact. Cranial nervous system examination, left eye lateral rectal palsy, present. And in motor examination of motor system, bilateral reflexes 2+ with a plantar downward. Sensory system, nil deficit. And cerebral system examination, horizontal and torsional nystagmus was observed. And in meningeal, there was a meningeal signs like a neck stiffness present, and the joint accentuation test both became positive. Another system examination of normal. Differential diagnosis considered initially were acute pyogenic meningitis, cerebellum abscess or brainstem abscess, cerebral venous thrombosis, and or complicated otitis media. Investigations with hemoglobin showed 10.5 grams with a total count of 12,500 and neutrophils of 94% with a thrombocytopenia. First, to proceed with the lumbar puncture, we have done a non-contrast MRI brain in view of pregnancy. It showed acute inflammatory changes in right medullary cavity and mastoid hair cells filled with the fluids, and features of meningitis seen, and brainstem and cerebellum were normal, and no space occupying lesion. All dural venous sinuses were normal, and no features of increased intracranial pressure. So here the mastoid hair cells filled with the fluid. So based on the no evidence of increased ICP, we proceeded with the CSF tapping, and the CSF glucose is less than 5, CSF protein is 390, and cell counts of total WBC 3680 cells per and with the polymorph of 97%, lymphocyte of 3%, and the CSF culture has grown Streptococcus pneumoniae, which is sensitive to penicillin. So our diagnosis of acute pyogenic meningitis caused by Streptococcus pneumoniae with 6th cranial nerve palsy, probably secondary to the acute suppurative otitis media with the mastoiditis made. So initially we started her on meropenem with vancomycin and dexamethasone. After the sensitivity report, we stopped vancomycin and we continued ceftriaxone for 14 days and dexamethasone for a duration of 4 days. But during the second, at the end of completion of first week of an IV antibiotics, she complained of hearing loss of both ears and giddiness. ENT opinion obtained for the above complaint, a diagnosis of labyrinthitis made, and audiometry done immediately, and it showed a profound sensory neural hearing loss of both ears. I'm going to discuss about neurological complication of pyogenic meningitis. So normally the invasion of the subarachnoid space by meningeal pathogens that leads to multiplication of organism and lysis of organisms by the bactericidal antibiotics, and that leads to release of the bacterial cell wall components like endotoxin, teichoic acid that cause production of inflammatory cytokines. These inflammatory cytokines can cause alteration of blood-brain barrier permeability, and then that result in vasogenic edema that cause intracranial pressure, or it increases the permeability of blood vessel with leakage of plasma protein into CSF that cause obstructive and communicating hydrocephalus and interstitial edema that in turn cause increased intracranial pressure. or the leukocytes migrate into the CSF and degranulate and release toxic metabolites that cause cytotoxic edema, stroke, seizures, and that also lead to increased intracranial pressure, or alteration in the cerebral blood flows, like increased blood flow or decreased blood flow, both can increase the intracranial pressure, and production of the excitatory amino acids and reactive oxygen and nitrogen species that cause cell injury and death, that also can lead to increased intracranial pressure. So the global and regional risk of disabling sequelae from bacterial meningitis, it is a systemic review and meta-analysis study. It in this study reviewed published paper from 1980 to 2008. It includes totally 132 papers. They divided the all the sequelae into major and minor sequelae. Major sequelae like both sensory neural hearing, both year sensory neural hearing loss. Minor sequelae like 1 year, single year sensory neural hearing loss. So the median risk of at least one major or one minor sequelae is 19.9%, and at least one major sequelae is 12.8%, and at least one minor sequelae is 8.6%. So the most common major sequelae observed was hearing loss, which is 33.9%. The risk of major sequelae was high in African, 25.1%, followed by Southeast Asian, 21.6%, followed by European region, 9.6%. Coming to the mechanism of bacterial meningitis related deafness. So here the most important mechanism proposed was the etiology itself. The bacterial etiology more responsible for meningitis related hearing loss. This was by this study presented at the 80th annual meeting of the American Laryngeal and Rhinological and Otological Society. It's a retrospective study of 547 cases of meningitis. In this case, 236 cases of bacterial meningitis and 304 cases of viral meningitis and 7 cases of fungal meningitis. Among 236 cases of bacterial meningitis, 23rd% suffered a partial sensory neural hearing loss, and 21% suffered complete sensory neural hearing loss. Among 7 viral meningitis, 3 developed sensory hearing loss with signs of retrocochlear site, and none of the 304 viral aseptic meningitis developed sensory neural hearing loss. On the other mechanism for meningitis-related hearing losses, the site of histological damage. The proposed site of histological damage associated with the meningitis-related deafness were cochlea, auditory nerve, auditory cortex, and auditory brainstem. Both studies in human and in animal demonstrated that cochlea is the primary source of meningogenic lesions, including damages to the air cells, supporting cells, and stria vascularis and spinal segments. The other mechanism is suppurative laryngitis and ossifications. Histopathological study of temporal bone suggested that the probable cause of sensory neural hearing loss is serous or purulent labyrinthitis, followed by ossification of labyrinth, noted to occur within an year after meningitis. In our case, we are thinking like this is the proposed mechanism for her sensory neural hearing loss. A pathological process mechanism, extension of the meningeal infection from the subarachnoid space via the cochlear aqueduct or interauditory canal to the inner ear result in labyrinthitis, and that can result in end organ lesions. And the role of cytokines, most importantly TNF alpha, and the reactive oxygen species, reactive nitrogen species that cause disruption of blood labyrinth and barrier, cytotoxic effect on air cells, and on cytotoxic effect on spiral ganglion directly. So based on this role of cytokines and oxygen species and nitrogen species, here plays the roles of dexamethasones. So dexamethasones prevent the action of cytokines and reactive oxygen species nitrogen at the early stage and prevent the development of the neurological sequelae of hearing loss. Another study, that's a repeated audiometry after meningitis, the consequence for further management. In this study, it's a retrospective cohort study done in 655 patients suffered from bacterial meningitis between 1985 and 2015. The incidence of hearing loss more than 25 decibel was 28%, and incidence of hearing loss more than 80 decibel was 13%. The normal hearing at initial assessment after treatment of meningitis remain stable over time in all these remaining patients. So during the study, they observed young children In children, profound 12% are developing profound hearing loss, and children between the age group of 4 to 17 years, 21% are developing profound hearing loss, and adults more than 18 years, 13% of chance of developing profound hearing loss. And they followed up with the repeat or the 110 patients with repeated audiometry. That 82 patients have normal hearing at the immediately after discharge. They were a stable sound. Among this, 76 stable throughout the life, and the 7 stable normal, or 1 year is stable, and other year is fluctuating hearing loss. And with the 29% presented with hearing loss after discharge, 19 were stable. Among this, 18 stable in both years, but 1 stable in normal year, and 1 year is fluctuating. And 6 among 29, 6 showed improvement. 2 bilateral hearing loss, 2 with bilateral hearing loss showed unilateral improvement, and 1 with bilateral hearing loss improvement. And among the 29 hearing loss, 2 deteriorated, and among the 29, one people is fluctuating. There is a study, prospective randomized double-blind study, to show that dexamethasone to prevent neurological complications. Total of 301 patients. Among this, 157 patients received dexamethasone, and 144 belong to the placebo group. There was unfavorable outcomes in 26% of dexamethasone group compared with 52% of the placebo group. So this study concluded that yearly treatment with dexamethasone improves the outcome in adult with acute bacterial meningitis. So our final diagnosis in our cases, acute pyogenic meningitis caused by Streptococcus pneumoniae with a complication of sixth cranial nerve palsy and sensorineural hearing loss, which is right moderate sensorineural hearing loss, with the left severe sensorineural hearing loss, which is secondary to the probable acute suppurative otitis media with the mastoiditis and labyrinthitis. So discussion. So here
we may have to. The next group is already waiting for the meeting, Lakshmi, and anyway, your time is up. You want to tell us which your last slide is so that we can just finish?
Yeah.
Sorry to interrupt, but somebody's waiting for this room.
This is bacterial meningitis during
go to your last slide
with your take-home message.
Yeah. I think it's the previous one. Stop.
Now tell us your take-home message.
Yeah, tell us.
Prompt initiation of antibiotics and dexamethasone, because our patient presented at second day after the illness, so it may prevent the development of sensorineural hearing loss. And audiometry assessment need to be done for all the meningitis patient after discharge. Despite the decreased mortality of meningitis with the advent of effective antibiotics, the mortality from meningitis still remains significant. And another slide I want to highlight is this was the patient report, the literature showing new.
No, it's okay. Your time is up. That's why, and somebody else is also waiting. So we okay.
So tell 1 point.
Yeah, tell us 1 point.
These slides, you tell us what you want to tell 1 point.
I think Lakshmi, just tell us the point you wanted from the slide. Yeah. Like a 1 slide which summarizes that slide. 1 line. Sorry.
Bacterial meningitis during pregnancy is an uncommon disease with a substantial mortality for both mother and child.
Thanks, Lakshmi. Sorry, in the interest of time, we'll have to talk. Thank you, everyone. I think Namrata talked to us about leukocytosis and the reactions. Janvi about PLHRV with lymphoma and outcomes. Shannon, unusual manifestation of the OP poisoning at different time. Christina's was a very thoughtful presentation on her cerebrotendinous, patient, and of course, Lakshmi. That's a jolt oxygenation test, not the joint oxygenation test where you suddenly shake your head and you can get headache and meningitis. Deafness, yes, we do give steroids to prevent that. Unfortunately, this patient has progressed. So thank you all. Very thoughtful presentations. Time management should be a little better, and today's gift goes